I wish you all the best program. Jai Hind, Jai IAP. Over to Dr. Vishnu for further proceedings.
So, thank you, Joe sir, for your address. Now I request dear Krishna sir to take over for the further proceedings. Krishna sir, Dr. Fiji and Dr. Rose.
Hello. Hello.
Audible,
Yes, sir.
Krishnan.
Audible. Okay, so thank you
all
for
the best program. Over to Dr. Vishnu for further proceedings.
thank you for the organizers for giving me this chance to being a faculty in this prestigious session. I think we will straight away start. Dr. Fiji, you are here.
Yes, sir. Yes, sir.
Yes. So we will start, isn't it? We will straight away start. So we can start from the presentation. Dr. Rose will, our senior resident JR3. So she was very interested in nephrology. She has won prizes for the nephrology quiz programs and all. So she's also very interested in this field. So Rose, please start. You can start your presentation.
Okay, sir. Good evening, all. Presenting Mohammed Swalih, 5-year-old boy, hailing from Nelambur, Malappuram district. Informant is mother, and information is reliable. Date of examination is on 23rd of May, 2023. Presenting complaint, puffiness of face of 4 days duration, abdominal distension and swelling of legs of 4 days, and reduced urine output for the 2 days. History of present illness. Child presented with puffiness around eyes, which was noted early morning and reduced by evening. It started 4 days back. On the same day, developed abdominal distension, which was gradually progressive. Developed swelling over the genital area. Also noted swelling around the both legs. The child also complains of, mother also complains of reduced urine output for the past 2 days. Last urine output was past 2 hours before during the examination. And child also had abdominal pain, which was diffuse, just not related to food intake, and pain subsided within 1 to 2 hours without any medication. Child also had 2 episodes of vomiting 2 days back, which was non-projectile and non-bilious vomiting. Vomitus contained food particles and no further episodes of vomiting. No history of any fever, cough, pain during urination, loose stools, or any rash. No history of any high-colored urine. No history of any pyoderma or sore throat. No headache, blurring of vision, altered sensorium or seizures. No history of any breathlessness. No lethargy, poor activity, or poor appetite. No history of any jaundice or bleeding manifestation. With these complaints, child came to hospital. Urine and blood investigations were done, which was abnormal, hence admitted here. And child was started on IV medication, which was given thrice daily, and also oral medications were given. Child was advised to restrict salt in the diet and also to take oral fluids. Past
okay,
history.
so before going to the past history, let us discuss your history till now. That is history of presenting illness. So for the participants, please send any doubts or any doubts, any point to be clarified in the message box, please. So history of presenting illness we have discussed in detail. I think this is the most important part in the history when you approach any case. So the 3 important points you considered is one is the child is having edema, and child is also having abdominal pain, vomiting, and decreased urine output. So these are the 3 important points, isn't it?
Yes, sir.
Okay, so So what are the important what are the important problem this child is having? So what do you want to communicate? This child is having edema. So what are the
Child.
important clinical conditions child is having from your history? So please, can you characterize each symptom? That's also important.
Child is having edema, which was initially noticed over the eyes and which was gradually progressing to involve the both legs and abdomen. So there is, and also the genitalia was also involved. So there is a severe edema. There is massive edema is present. And
okay, so that you are mainly concerned about the severity of edema, okay, isn't it? So that's why
yes.
you are telling that this child is having severe edema because why?
Because the edema is extending to involve the child is the abdominal extension might be due to the ascites, and also the genital area is also involved. So there is there's severe edema.
Okay, so there is ascites, genital edema, and what about in the limbs? Lower limb, is it how far it is extending?
It's extending up to just below the knees.
Below that. Okay, so this is why you are telling us, sir, it is as a massive edema. Okay, so any other more objective method you would like to look for to assess severity of edema in a child?
We can also ask the weight gain also.
Okay.
So
what is the okay? What is a criteria for assessing edema regarding the weight gain? You told weight gain
is less than, so weight gain is less than 7%. It is mild edema. Weight gain of 7 to 15 8 to 15% is moderate edema, and more than 15% is severe edema.
Okay, very good. So in this case, did you consider objectively assessing the edema by more objective method? So was there any previous weight documented in this child? Did you ask for that?
Yes, sir. Previous.
And what is today's weight? You might have taken today's weight. So is there any, what percent of weight gain you got?
There is a weight gain of 2 kg.
So how much it comes? What percent of body weight child gain? Is it exceeding massive edema? So that is the one thing you can do. So you can calculate the weight person. If you know the previous, most of the parents will be knowing the last documented weight. So today's weight you will be invariably taking. So better you make an objective assessment of edema severity. Okay. So there is a 2 gram weight gain. So obviously it will be more than 15%, isn't it?
Yes, sir.
Yes. So what is the relevance of severe edema in this case? This child is having something with edema. Probably it's an nephrotism, but you know that. So why did you assess the severity?
Because the management also differs depending upon the severity.
Okay. Management. What management you are referring?
If the child is not having any hypovolemia, then for the massive edema, we would start diuretics.
Okay. So any child with this massive or significant or severe edema need to be treated by using diuretics, isn't it?
Yes, sir.
So that's the point that she made. So that means that severe edema this child is having. She has assessed the edema objectively as well as by the clinical findings, by which sometimes the clinical findings may be the only thing is available. So you want to manage this case with using drugs, diuretics. Okay, so we will be later on going to the management part. Okay, so Fiji, anything regarding this edema you would like to add?
As one of the participants have asked, whether this edema will progress to severe ascites and all within 1 day. That is a question in the chat box. So probably mother might have ignored the puffiness for the previous few days. Only when there is this abdominal distension or genital edema, they noticed or give importance to puffiness. Isn't it so, Rose? Usually
yes,
it will not occur over 24 hours.
Yes,
so that depends on the ignorance or the educational status and awareness of the mother. Early detection of puffiness is important, and probably this is overlooked by the mother. Isn't it so?
Yes, madam.
There is a doubt in the chat box.
Okay, the mother noticed edema, mother giving a history that the edema and the ascites developed on the same day. Probably she might not noticed it.
Okay, so that's right. When somebody has asked this very important question. So what is the relevance of this question? Why that this is a rapid development? What is the significance? Is it anything related to the management or anything related? What is the relevance? So is there any relevance? Why suppose there is a rapid progression? What is important?
If it is rapidly increasing, if it is abdominal distension or ascites, we have to rule out any SBP.
SBP, okay. SBP will not be causing rapid increasing, but a prolonged edema, there's a high risk of chance in developing infection, but rather than rapid edema. So can the person who asked can answer that? Rapid MPGN. So, okay. So the thing is that if the child is developing a rapidly progressive edema, there is a high risk of that child developing acute renal failure. That's more important because if there's a rapid accumulation of ascitic fluid, it can cause a significant reduction in the renal blood flow. This can cause acute kidney injury, anuria, and so the entire management may be very difficult. So that may be the one. That is the one reason. Other thing is that there is a high chance of the child developing hypovolemia associated. If there's a rapidly developing edema, because the albumin should be very low.
One point.
Okay, sir. Please.
Abdominal pain also in this context is important because.
Okay, so we are coming to that.
Early, very unlikely to be due to the commonest of the situations which we think the pneumococcal peritonitis in a context and which is happening in the first few hours and the very rapid progression of edema, as you said, the onset and progression and the fluid going into the interstitium and the hypovolemia. The abdominal pain in this case must be due to mesenteric ischemia. So both these situations are arguing for a little the prognostically important.
Okay. Yes, that's true, sir. So that's why the rapid development edema could be either can be leading to acute development of hypovolemia, as in this case, there's a probably acute abdominal pain is there. Other thing is the risk of AK also. So now I think the second point you made, what is another important the presenting symptom characteristic is the abdominal pain. So what is the relevance of how do you relate this abdominal pain in this case at this moment, Rose? What is it due to? Do you consider spontaneous peritonitis, or is it as told mesenteric ischemia due to hypovolemia, or is there anything else? But after the analysis of the symptoms, what do you concluded? Because you want to manage this case, isn't it?
It can be due to hypovolemia because there is a history of reduced urine output, there is history of vomiting, and there is no history of any fever also. So we have to rule out hypovolemia because it is a cause for abdominal pain in nephrotic syndrome. And other causes can be the drugs which the child have taken. It can cause especially steroids, or it can be due to spontaneous bacterial peritonitis. But here there is no fever in this history of any fever here.
Okay, so it's good that you have considered the spontaneous bacterial peritonitis because one should not miss bacterial peritonitis. So you have asked about symptoms like fever, lethargy, decreased appetite, decreased activity. That is a systemic toxic symptoms you have included, and fever also you have included. That's evident that you considered spontaneous bacterial peritonitis. Very good. And other causes, gastritis, but there is no intake of any steroids and very unlikely. So what are the other causes of acute abdominal pain you should be considering? Another important one is hypovolemia is the commonest. Second is spontaneous bacterial peritonitis. That is another serious complication which can cause acute abdominal pain other than
renal vein thrombosis.
renal vein thrombosis. Very good. So renal vein thrombosis also, what are the symptoms you have asked for that in this case?
Is any high colored urine, no of any high colored
Okay,
urine.
hematuria, gross hematuria, red colored urine, and oliguria. Yeah, isn't it? Oliguria, acute renal failure, and what is hematological manifestation of renal vein thrombosis? Hematological, associated with the, suppose you met the petechiae. Petechiae is the hallmark of. Petechiae occurs due to what? Which cell count is reduced?
So it is not clear. Question is not clear.
No. What is the hematology abnormality you get in renal vein thrombosis? You can get acute kidney injury, hematuria, and CBC
There
may
can
show.
be mass palpable.
So somebody, no, I think you are not hearing my question.
Sir is asking what is the hematological abnormality expected in renal vein thrombosis leading to this petechiae.
Okay.
Where will you get the petechiae? Which cell is reduced? Direct question. The thing is that thrombocytopenia. Thing is that during your case presentation, the question can come go to any direction. So you should have very concentration. Should be very. You know the answer. All of us know. Okay. Okay. So Fiji, anything to add that? So regarding the other cause of abdominal pain, you have to clarify, isn't it?
Urinary tract infection.
Yes, UTI can cause. Then other rare causes of abdominal, rarely there may be renal vein thrombosis told. Acute pancreatitis has been mentioned, one of the rare causes. And bowel wall edema can also cause acute abdominal pain. And the other thing is that during the early, if the ascites occurs rapidly, it can also cause acute abdominal pain. Initial, if the as in the question one somebody asked. So if there's a rapid ascites develop, it can cause stretching of the peritoneum and all. It may be it can cause a transient abdominal pain. So that also one should consider. So abdominal pain coming, and after few hours the abdominal pain disappearing could be due to the rapid ascites. Okay, so the third important point you point out is that urine output. So what is your how did you approach this urine? What is the what is the cause for the urine output? What do you consider? Is an important symptom in a child with nephrotic syndrome?
Reduced urine output can be due to AKI.
In this case, do you consider AKI?
And also, as per from the history, there is no reduced oral intake. Child is taking, it was taking well.
But you told there is a vomiting. So can it be due to oliguria due to vomiting? Is it that is related immediately after vomiting and developed urine output?
On the same day,
the common cause of oliguria is pre-renal, isn't it?
Yes, sir.
So that point is not clear because this could be a transient oliguria you told. So developing acute kidney injury is a significant event in a child. You have to manage. You should be you have to manage this massive edema, diuretics you have to use. Already there is acute kidney injury, so you will be having some confusion to start diuretics. Whether you start albumin infusion also may be a problem. So you have to at this level, by history wise, you have to clarify: is it oliguria due to hypovolemia, that is a decreased fluid intake, or acute kidney injury? So that point you haven't cleared, I think. Sir, in the Purushottam sir, isn't it? What is your comment on that?
Yes. About in the initial presentation also, better avoid the Rose mentioned ascites, because at this stage you can't, you are not in a position to say ascites. We considered inoxonline also vasculitis in the initial one of the reasons for abdominal pain. HSP.
She mentioned that there is no rash.
Just rash, no rash should be mentioned. This one because it can be a bleeding, it can be another sort of vasculitis. So no rash she mentioned. Okay.
Yes. So as far as possible, avoid the medical terminologies, as I've already pointed out. So you can say that there was a swelling, abdominal distension, etc.
It's mentioned in as abdominal distension actually.
Yes, some may not be always acceptable.
Okay, sir.
Anyway. Physician, we will move to the so you consider the oliguria, whether it is AKE or due to the
video
fruit, you are not very sure.
Krishnan, I think
video
off ചെയ്ത കുറച്ചുകൂടി audio clarity വരും.
Okay. ശരി. ഇപ്പൊ ശരിയായില്ലേ? Okay. Okay, so
whether high colored urine is sufficient or whether she should mention reddish or cola colored urine.
I think for hematuria, as Fiji is okay. Yes, that I think it's cola colored
concentrated urine also.
Concentrated urine also. I think she has mentioned it due to hematuria. You consider hematuria. So if you are considering hematuria, better cola colored urine is a better term. High colored means usually it is concentrated urine. So you can also include was there high colored urine or a cola colored urine, because high colored urine maybe you can take it as a point in favor of a oliguria due to the hemoconcentration or hypovolemia. Okay, so we will go to the past history.
Past history. That's a similar episode in the past. First episode 2 years back, that is at the age of 3 years. Started as facial puffiness of 1 week and abdominal distension
Before
of 3.
Rosie, 1 minute. For the other candidates, so when you present the acute nephrotic syndrome presenting with edema relapse, so the most important thing is you have to identify the complication, because relapses are the complications more commonly occurs during relapses. So most of the relapses may be associated with significant complications. So that is the point we discussed. So was the child having massive edema? Was there any SDP? Was there any hypovolemia? Was there any renal vein thrombosis? So significant complications whether child was having. That was the point. So you will be elaborating on the history in the history presenting illness when you address when you see a child with relapse. Okay, past history.
Similar episode in the past, first episode 2 years back, that's at the age of 3 years. Started as facial puffiness of 1 week duration and abdominal distension of 3 days duration. Child was admitted and advised daily urine testing and started on oral medication, oral prednisolone. Edema subsided after 2 days. No history of any high BP recording at that time. No cola colored urine or reduced urine output. No history of any IV medications or ICU admissions. Urine testing was normal after 8 days, and child was discharged on day 10 of hospitalization. And mother was counseled regarding the course of the disease and the need for long-term medication. Oral medications were continued on daily treatment and for 6 weeks, and then on alternate days with reduced dose for next 4 months, and was stopped. And we lost follow-up after that. Then first relapse that is at the 1 year back in February 2022.
Okay, so you have Rose has gone. Yes, continue.
First relapse 1 year back in February 2022. The child at that time had facial puffiness and pedal edema. was associated with fever and rhinitis. The child was treated from nearby hospital on OP basis with oral prednisolone, and drugs were continued for 4 months and then stopped. Then after that, second relapse in June 2022, developed 1 month after the stopping steroids. Child had facial puffiness and pedal edema. It was also treated from nearby hospital with oral medications and was on tapering dose. Exact details and exact history is not available from the mother. Then again in the October 2022, that is third child developed generalized edema, which was preceded by fever, and child was referred to our center. Steroids were given a daily dose for 2 weeks. The child had high BP recording, for which a drug was given for 1 month, which was stopped once BP was normalized. Steroids then tapered to alternate days, which was then tapered gradually, and then child was on 10 milligram per day, 10 milligram on alternate days for the past 2 months while developing this relapse. No history of any recent reduction in the dose of the steroids. Ophthalmology consultation evaluation was done. It's said to be normal. No history of any difficulty in climbing stairs or getting up from squatting position. No history of any rash or joint pain. No history of any allergy or asthma. No history of any varicella or tuberculosis in the past or any contact. No history of any jaundice or blood transfusions in the past. Coming to the birth history.
Before I would like to discuss the past history. So as expected, the past history was elaborated on. First episode has been elaborated. Second episode, all the relapses has been also elaborated. So most of the time, when you get a case of a nephrotic syndrome, it will be either resistant nephrotic dependent or frequent lapsing. So the major part of the history will be the past history. So you are supposed to concentrate, describe, as in this case, first episode of nephrotic syndrome should be in detail evaluated by all the extracting all the history, all the points, and subsequent relapses also should be history should be elaborated by taking detailed history. So in the first episode, what are the points, Rose, you would like to highlight regarding this diagnosis, management, and prognosis of this child? So you just for the all the participants, the points you would like to highlight.
Child attained remission early after
early
1 week
remission.
Early remission. And there is
so
no
what is the usual
complications.
time which delayed remission you consider? So you please clarify that. So when do you consider a delay and the relevance? What is the early remission and delayed remission? What is the consequence?
The remission attained in within 1 week, it is early remission. Less than 1 week, it is early remission. If it is no remission after 4 weeks, then it is delayed remission. And if it is no remission at 6 weeks, then it is steroid resistant.
I think I would like to interfere here. I think it's not 4 weeks. 4 weeks we have to consider the resistance. So you'll be going to resistance. So the early remission means by 7 to 14 days, if there is a remission. So even after 14 days, if the child is not getting remission, you take it as a delayed response, late resistance, 2 weeks. So that is the cutoff point. For if the child is not attain remission, even after 4 weeks, you have to evaluate for if the child is going to resistance. So it is the 2 week cutoff usually. It is not given. Most of the articles it is not given. So usually accepted is 2 weeks. Sir, Purushottam sir, anything add clarification needed?
Yes, 2 weeks. Usually 2 weeks.
2 weeks. 2 weeks.
Beyond 4 weeks, it's considered situation.
So it's that's why the discharge remission attained early. So what is the implication in this case? Remission attaining within 2 weeks.
It's a good prognosis.
Prognosis for the child is less likely to have a dependent or frequent lapse, isn't it?
Yes, sir.
Okay.
And also
Okay. Any other point?
No history of any complications during the episode. No hypertension, no hematuria or AKI, or any history of any infections requiring no history of any complicated relapse.
Okay, so
Or
you are
non-linear
concerned about
relapse.
the complicated relapse. So what is the definition of so you could tell us what is a complicated relapse?
Complicated relapse if the child have any hypovolemia requiring ICU admissions, or if the child have any infections, that is peritonitis, cellulitis, or pneumonia, or if there
Okay.
is any thrombosis, then we take it as a complicated relapse.
Okay, so thrombosis, significant severe invasive infections, severe hypovolemia requiring hospitalization. Massive edema is also taken as massive edema requiring prolonged hospitalization also, and severe uncontrollable hypertension also, and acute kidney injury. If it is need prolonged hospitalization also is a complicated relapse. So this case was not a complicated relapse in the first episode. Was it?
Yes, sir. No history of any complications. It was a simple episode.
Okay. So what is about blood pressure? What is the relevance? You mentioned normal, no hypertension.
Yes, sir.
Suppose
Hypertension.
that is you are detecting hypertension in the first episode of production. How will you consider that? Because do you consider a significant lesion of Brody syndrome, or can it be still a minimal change disease?
It can still be a minimal
frequently
change
you will get
because,
hypertension.
in 10 to 20% of minimal change disease can also have hypertension. So it can be still be a minimal change disease, but it can also be.
So that is the answer. So you can expect a hypertension, but it will be over by the time child attains remission. So if the hypertension persists even after attaining remission, so you should consider some other possibilities, other etiology. So that is the thing. So 20% can develop. What about hematuria? Is it suppose there is a hematuria, gross hematuria? Suppose this child mother gives history of gross hematuria, color-colored urine in the first episode.
Hematuria, microscopic hematuria can be seen in minimal change disease. If it is persistent microscopic hematuria or gross hematuria, then we need to evaluate.
Okay, so that is the 2 points. So if the microscopic hematuria extend beyond 3 persistent months. Means beyond 3 months. Persistent means beyond 3. Even after 3 months, is the microscopic hematuria persists. And if the gross hematuria persists, it present early. Usually it is a 2. Even after 2 weeks, it is not coming down. You have to do a renal biopsy. It's a typical feature somebody has pointed out. So you have to do a renal biopsy. So it could be some significant lesion. So that point also you have considered. So 3 points you have mainly considered: how early child develops remission, was it a complicated relapse, was there any persistent hypertension, was there any persistent, was there a gross hematuria or microscopic hematuria also? Fiji, anything in this?
So the age of onset is also important, sir?
Yes.
Less than 1 year or after 1 year. So the first episode, when it started?
First episode at the 3 years of age.
That also may be giving some clues regarding the prognosis, and whether this baby was admitted or treated in the OP basis, whether parents are well counseled and educated regarding follow-up, whether they are doing this home urine testing. That also you can mention. You mentioned no IV medications. Was the child admitted in the first episode and properly educated about the disease?
Yes, madam. The child was admitted during the first episode and was advised regarding the need for the follow-up and need for the daily medications. Actually, they were doing from the home, but due to some socioeconomic issues and all, they were not able to follow up.
Oh. That's all.
Okay, so that's also important. Whether the parents has been educated appropriately is also very important for the long-term prognosis. Prognosis is very important rather than the disease alone, because the majority of the management, early detection of relapse, the early detection of relapse very, very important, because once the relapse worsens, it can develop complications. And the adherence to treatment, everything, follow-up visit, whether they are visiting very properly at the regular follow-up, all these are very, very important. Has got important effect on the prognosis of any child with an Nephroid syndrome. So that should be assessed appropriately when you see the patient first. And that point has been highlighted. Okay, so
You're going for beyond the past history or completed past history?
no, one more thing, she has gone into details about relapse. So after the
past history part, I think
yes.
for the postgraduates, this detailed analysis of a past history is very important, because that is how you're differentiating different types of frequent relapsing, steroid dependent, or the other types. In a case like this, the typical age of presentation, as Fiji pointed out, all the points are needed for the prognostication and the planning. One very good thing is at 3 years. And after that, very good response. The patient is lost to follow-up. In a case like this, what happened in the next 2 years? There can be 3 possibilities. One thing, the detailed analysis is possible because the patient is definitely under our follow-up only, all the treatment. There, you can clearly make out what type of the pattern of the presentation. Is it a steroid responding type or dependent type, frequent relapsing? That's all possible. But in a case like patient lost follow-up, it can be 2 situations. It can be going to another practitioner, maybe an adult nephrologist or a general practitioner, or third possibility, or Ayush. Totally, it's not a modern medicine at all. So in the third group, where you are going for Ayush, there is another problem. They may not be giving these drugs in the proper manner. They may not know about the complications. They may be putting on some nephrotoxic drugs also, some heavy metals or renal damaging things also. So from where they are taking the treatment is important. In this case, we didn't follow the patient, but another modern medicine doctor followed up the patient. The first part was okay. And the second remission and all, you said that 4 months were involved. So that's a bit unusual. What was the pattern of the drug intake during those 4 months? That's a bit clarity is lacking there. And as the end part, it's more and more closer together. As already we discussed, there is no complicated relapse, but the frequency seems to be a little more frequent in the last 2022. So all these details are very important in the past history analysis of the progression of the illness is very important. You need to go in depth. And also the toxicity problems of the drugs also. Thank you, Krishna.
Okay. So regarding the relapses, what is your comment, Rose? Is it the frequency of relapses you have outlined?
Yes, sir. It was first episode in the February 2021.
Okay.
Then first relapse around after 1 year, that is in the February 2022.
So is it a good, what is the comment on that? Relapsing after 1 year only. So it's a, regarding prognosis,
it's a good prognosis.
It's a good sign. Good sign. Okay. Okay.
Then second episode in the June 2022.
Okay.
And third relapse in the October 2022. So it is an infrequent relapse because it is not occurring within the 6 months of the first episode. And also there's no there's no 3 relapses of any 6 months, because first in the February, third in the October, and also the fourth relapse occurring in May. So it cannot be called as a frequent relapse.
Okay, so the frequency of the relapses you got is not fitting into any of the definition of either frequent relapse or Nephroid syndrome or dependent Nephroid syndrome. That has been so. For the other participant, this part is very, very important. She has outlined how frequently each relapses occur. May be difficult, as Sir has mentioned, because if the follow-up is not optimum, you may be very confusing also. So at least try to delineate how much relapses occurs, what is the interval between the relapses, and what is interval between the first relapse and the first episode. That is another important thing. So in that case, one may get some confusion. Is it a first relapse occurring after the onset of the symptoms, or after starting the steroid, or after stopping the steroid you take for the documenting as a first relapse? So if it is within 6 months, it's an early relapse. So what is the cutoff point you take?
After completing the treatment.
Yes, it is after completing the treatment. That is 6 months, 12 weeks after the first episode of initiation of steroid you take. From that point to next 6 months. That is the time by which you say is it early relapse or not. So, and that is another point needs clarification. So this is an infrequent relapse. But from the history you told, it's a child was receiving a long-term load of steroid. You have
Yes, sir.
given that. So what is the
from
reason
the-
you consider? So is it what happens to that? Did you try to go into detail? That is unusual, isn't it? Child was wrongly taking a low dose long-term steroids. So your assessment says it is not a frequent lapse.
Yes, there is a lack of clarity in that part Rose mentioned, because what was the pattern of drug intake in between the last two relapse is not clear. Whether it happened while on totally free of drugs or whether she was on some small dose. That part is a little clarity is lacking.
The second episode, after the first episode, child is off treatment for around 1 month. Then the child was on medications, but the mother doesn't remember how much is on, what the child is on. The mother tells that she's on, the medications were tapering. Initially, it was given twice daily. Then it was given on the on a single dose, and it was given on the alternate days. And the dose was also reducing. That's and she was on some low dose, but exact dose and all she's not remembering, and the details was also not available. And then in the October 2022, the child was on medications, and child had fever and developed this edema. And after that, child was referred to here, and we started. We again took it as a third relapse, and we given medications, and it was on tapering dose. And actually, the for the child visit, it came here in the February. After that, they didn't came also.
So how can you explain this point?
So we were tapering the steroids.
Okay, maybe due to the poor lack of adherence to treatment or lack of follow-up in the same center, multiple treatment taken from multiple centers. All this may be having problem with giving a correct history. This can happen to anyone. So we can also face the same situation. You can explain like that, because they were not giving a regular follow-up. That may be given a wrong history may be obtained. And counseling also may not be some. This child, what is inference? What is inference regarding the counseling of this child, of this parent? So this mother need more counseling, even though it has been several years, 1 to 2 years. This mother need, that's the one inference you have to make out.
Okay.
Okay. Yes, continue remaining.
Antenatal history. This is a first child of non-consanguineous marriage, born to 36-year-old elderly mother, conceived after 1 year of.
Okay, so if there is nothing relevant, you can go on to next.
So term LSUs, it is nothing relevant, sir.
Birth weight is normal birth weight, isn't it? That is important because the growth pattern you will be measuring and monitoring the growth. So this way it was a normal birth weight, well baby. Birth weight was normal. Okay, continue.
Development is normal and up to age. Vision and hearing is normal. Child was enrolled in LKG but attended school only for 1 month due to the illness.
Yes.
Diet history. Child was exclusively breastfed till 6 months, and complementary feeding was started at 6 months with ragi. Now shares family pot, but diet is deficient in good quality protein. And there is no food faddism. And during the edema, child is advised to avoid excess salt. There is a deficit of 150 kilocalories and getting adequate protein.
Fiji, anything
Immunize-
you would like to ask, Fiji? Diet.
Any fat restriction or any other restrictions advised?
No,
Or
during
mother
the
is
episode
no-
of during the episode of edema, they were advised to avoid salt. Otherwise, no other restriction was given.
Okay, I think at this point we will discuss the diet to be advised in Approach syndrome, because we will clarify that. So, what is the usual diet you will advise for children with Approach syndrome? How will you counsel the parent regarding the diet?
Protein according to the normal required recommended daily allowance should be given, and restrict fatty diet during fats, and also carbohydrates also should be minimally restricted. And during the episode of edema, we have to restrict the excess salt. That is the normal salt in the food can be allowed, but excess salt in the food container is puppet, pickles, etc. should be avoided during the episode of edema. And once remission attained, the child can.
Okay, so that's I would like to just wind up, because one thing is during the relapses only you restrict the diet and all. Once the child is out of relapses, you give the normal good quality, that is normal nutrient. A nutritive diet should be given, balanced diet should be given during the normal period, and during the relapses and during the high dose steroids. If the child is taking high dose steroids and during relapses, you have to restrict the salt. And very low, if the child is having severe massive edema, the salt should be significantly reduced. Not at all the high salty food. You have to restrict the significant reduction. Otherwise, control of the edema may be difficult, because mainly sodium retention is one of the important components causing the massive edema. And regarding the carbohydrate, better always give a complex starch, complex carbohydrate. Avoid simple sugar, because it will increase the hyperlipidemia. It will stimulate the synthesis of the triglycerides and the fat cholesterol. So that should be restricted. So avoid giving bakery foods like all the sweet items should be avoided. Regarding the fat, restrict the fat, and especially avoid the saturated fat. That is the thing you have to avoid. And the fluid during the relapses, you can advise normal fluid, except there is a massive edema. Fluid restriction routinely not advised except during massive edema. Suppose there is a hyponatremia, sometimes you may get very frequent finding, you may get hyponatremia. If there is significant hyponatremia, the fluid should be restricted significantly. 1/3 should, 2/3 should be, 2/3 restriction should be given. Otherwise, because there is a risk of hypovolemia. So a mild moderate edema need not always restrict fluid. Only if there is a massive edema, you restrict fluid. And during the follow-up, vitamin D, calcium-rich food should be given. One thing you can practical advice is that whenever they take a tablet in the morning, so after breakfast, you give 1 glass of milk. And after that, then only give steroids. That will provide calcium significantly. Okay.
Immunization history. Child is immunized up to age. Optional vaccines taken, which was taken after the first episode. Pneumococcal vaccine, 2 doses of PCV13, and varicella vaccine, 2 doses were taken. Influenza vaccine not taken. No adverse events following immunization. Family history. This is the first and the only child of non-consanguineous marriage. No family history of any renal disorders or hearing impairment. No history of any tuberculosis in the family.
Excuse me, do you want to clarify, because a lot of questions you may get regarding the immunization. So I think we will discuss that point, isn't it? Fiji, isn't it?
Yes, sir.
Anything to ask? Anything ask? You would like to explain, or do we have time for that also? Or we'll leave them to read on that immunization? Or
No, it's better to discuss. It will be useful for the participants.
Yes, yes. So this child needed, apart from the routine vaccines, needed took the 2 doses of PCV13. So what is the next vaccine you will advise, and when?
PPSV 13, 8 weeks after the, it is given after 2 years of age and also 8 weeks after the last dose of PCV 13.
Okay. Then other vaccines, please elaborate.
Varicella, pneumococcal, varicella, and hepatitis B should be taken. Actually, child was given all these vaccines. An annual influenza vaccine was also should be taken. And child is pending vaccination is PPSV 23.
Okay, so one thing is the varicella vaccine routinely in this nephrotic syndrome, better you give at 6 to 8 weeks interval, 2 doses. Whereas in the healthy individual, it is a 3 to 6 month interval, you give 2 doses. That's one difference. And the influenza vaccine, you have to give annually. And the cutoff point for the PCV 13 below 6 years, 2 doses. Above 6 years, only 1 needed.
1 dose.
So these are the things. And the hepatitis B also, ideally in a child with high dose dependent nephrotic syndrome, you are supposed to check the hepatitis B titer, and if it is less than 10 micro international unit per ml, you have to give vaccine with the double dose. Adult dose should, that is all. The adult dose should be given. And regarding the family, any precaution you will advise regarding the vaccine? Suppose that is not in this case, child is taking a high dose steroid or immunosuppressants like cyclophosphamide or cyclosporine, what advice you will be following up this child? So regarding that, suppose they want to give vaccine, live vaccine for the healthy.
Cyclophosphamide, avoid live vaccinations after until 3 months, and for other CNIs, levamisole, avoid for 1 month, and for rituximab, if it is taken, we should avoid live vaccines, defer live vaccines for 6 to 9 months. And if there is any contact also for the siblings, they should not take oral polio vaccine, but can take other measles and other live vaccines can be taken to the sibling. And also the household contact should take annual influenza vaccine also.
Okay, so household contact should be annual influenza vaccine. And why do you want to restrict OPV alone? Why can't it be OPV also given? What is the reason for that? You are giving MMR and all.
Because it is spread by through the GAT.
Okay, fecal oral transmission, and more important is that if this child is immunosuppressed significantly, so if the child is happen to have a vaccine-derived virus mutation occurs, this child will be constantly excreting this vaccine-derived virus for years. It will be very difficult to eradicate. So it can cause a focus of outbreaks. So that's why don't take any chance for vaccinating this baby or any close contacts. So that you are mainly protecting the other community rather than the child. Okay. So, but the problem is this child, any child being, many of the pediatricians will be giving steroids, isn't it? So, what is the time for giving vaccinations while taking steroids? And at what time, on which dose? That's another important clarity needed.
The child is on high dose steroids more than 2 mg per kg per day for less than 14 days. Then the child can avoid live vaccine. Child can take live vaccines after the discontinuation of the steroids. And if the child is on high dose steroids, that is more than 2 gram per kg for more than 14 days, then live vaccines after 1 month of stopping the steroids. And if it is on the low dose treatment, the child can low to moderate dose steroids. The child can take live vaccines after discontinuation of the treatment.
Okay,
And in,
so
in an older child or a child more than 10 kg, 20 milligram is the cutoff, not more than 2 milligram per kg.
Okay, so these
So
are the
that
points.
will be important for varicella vaccine, because we are giving varicella vaccine while the child is after getting this nephrotic syndrome. So that point will be important in here.
So that's important because a child on steroid low dose, that is low dose means less than 20 mg
20 mg per day or
total
less than
dose or less than 1 milligram per kilogram body weight per day. If it is less than that, you can give even live vaccine. Killed vaccine you can definitely give, but live vaccine also on dose, low dose definition means 20 mg as a total dose or less than 1 milligram per kilogram body weight per day. Suppose a child taking 1.5 milligram per kg on alternate days also can be given. On alternate days, 1.5 mg. That is equal to less than 1 mg per kg per day. I think that point is clear.
And one more point I would like to add. If the child had exposure to varicella, vaccine can be given. If the child is not on any immunosuppressants, vaccine can be given within 5 days of exposure to protect the child for not already vaccinated. And this PPSV 23 can be repeated once again after 5 years if the child is still getting relapses. But not more than 2 doses of PPSV 23 is recommended for a child.
Yes. So varicella is very important because suppose a child with immunosuppression, especially high dose steroid or immunosuppression develops a varicella, it can lead to fulminant varicella, it can be fatal. So at any cost, you have to prevent the varicella. Whether it is immunocompromised, you have to give, you cannot give live vaccine. So in that situation, you are supposed to give acyclovir prophylactically itself. If the child is not immunosuppressed, you can give a post-exposure varicella vaccine within 5 days. Not within 5 days, indeed. Okay. Whereas if it is you are giving acyclovir, it should be only after 6 days.
6 days.
Of contact. That also, these things may be asked in the question as in the examination. So IVAG role somebody has asked. So in the last recent evidence says that IVAG preparations are not containing much immunoglobulins against varicella. So that's why even if you give IVAG, it may not give us any protection against varicella. So if the varicella zoster immunoglobulin is available, you can give it say 100% protection, almost very high protection. But IVAG is not assured because it may not contain immunoglobulin. So it is now not recommended. So following a contact with the varicella in a child with nephrotic syndrome, first line is if the child is not immunosuppressed, you can vaccinate. Or if the child is immunocompromised, give a prophylactic acyclovir. So that according to the latest IAP guidelines.
And you can mention whether BCG scar is there. Routinely, we used to mention that.
This BCG scar is present.
Yes, yes, yes.
Question is the dose of the acyclovir in a case like this with a severe immunosuppression, you can't give the post-exposure varicella, and there the choice is only acyclovir. In that situation, from 7th day onwards, are you giving a higher dose, 20 milligram per kg? Is it recommended? I think it's a little.
Yes, total 80 milligram per kg per day. 80 milligram per kg per day in divided dose.
That's right. That's right. It's not the usual dose. Usual
It's
dose
not the
is
usual dose.
10 milligram per kg. There are 80 milligram per kg. Very high
80
dose.
milligram. Yeah, high doses. Yes, yes.
And when you're giving acyclovir high dose, it's a little bit of renal toxicity also that you need to consider here in a case of nephrotic syndrome. For acyclovir, vancomycin, they're all having some renal toxicity. And about the influenza vaccine, the percentage, the dose is important. It's always 0.5, even in 3-year-old also. 0.5 ml, not 0.25 ml, which is the previous one. And only quadrivalent vaccine. Now it's only available one is a quadrivalent, trivalent is not the one available. And the latest strain, whether it's a northern or southern, whatever, the latest strain of the quadrivalent vaccine, 0.5 ml and 2 doses if it is the first time.
Okay, so there is one message in this regarding the definition of steroid resistant nephrotic syndrome. Actually, it is the 6 weeks. So if the child is not attain remission even after 6 weeks, you treat it as a resistant nephrotic syndrome. But you have to start preparing for treating as a nephrotic syndrome, steroid resistance from 4 weeks onwards. So what they have recommended is that if the child is not attain remission after 4 weeks, you give methylprednisolone along with the steroid. You give 15 milligram per kilogram body weight on daily at 3 dose, and you wait for 1 more week after giving a continuous steroid 2 mg per kg, and give added on that to 3 doses of methylpred and wait for 1 week, 1 more week. And if the child is still not attain remission, brand it as a resistant nephrotic syndrome and do biopsy and start cyclosporin and other treatment of nephrotic syndrome. So that is ideally it is a 6 weeks only.
Definition of the steroid resistance, there are 3 guidelines. The 6 weeks guideline also is there, and what you said, 4 weeks followed by 30 milligram per kg, 3 doses and all. I think
Yes.
we'll be most of us will be following the 4 weeks schedule rather than the other one.
Okay, so that is okay. So several recommendations, but according to IAP, that is a regimen that it's a 6 weeks. I think 6 weeks. That is from 4 weeks onwards. You have to prepare for renal biopsy. You have to give methylpred, wait for that, and because after 4 weeks, majority will develop remission if it is a steroid sensitive by within 4 weeks itself. But a small number of patients may develop a remission even another 2 weeks period. That is called the preparatory stage. That 2 weeks period that they have also termed like that. So there is a preparatory stage or for anticipatory stage of resistant nephrotic syndrome. So during these 2 weeks, a small number of patients can attain remission. There is a chance. So that's why that patient should not be treated as steroid resistant nephrotic syndrome, because the main thing, one of the important morbidities due to the treatment. Okay. I think we can continue.
Family history. Is the first and the only child of non-consanguineous marriage. No family history of any renal disorders or hearing impairment. No history of any tuberculosis in the family. This is the mother is now 42-year-old and father is 43-year-old, and this is the only child. Father has another wife and 5 children. Now, socioeconomic status. Father studied up to 10th standard and works as a driver. Father have another wife and 5 children, but takes care of this child and comes home once weekly. Mother studied up to 10th standard and is a homemaker. They lives in a rented house, 3 rooms, with sanitation, gets financial support from neighbors and relatives also. Now insured under Arogyaranam scheme after the hospitalization. They belongs to lower class family according to modified Kuppusamy scale.
Is there anything in this portion?
Nothing much, sir. Any family support is there? Child may require frequent visits. That is why they were lost for follow.
Yes,
This
madam.
travel and all, mother and child, whether they are alone at home.
Yes, madam. They were alone at home. The mother and the kid is alone at home, and they get support from the nearby and neighborhood. And father
Okay.
also comes once weekly. Father knows about the disease, but he has to take care of the other children also.
Okay, so this child, they need more frequent monitoring also, isn't it? So what is the practical advice you can give? Is that because whenever there is a lack of adherence, one method is you can put them under more frequent follow-up. Probably instead of 4 weeks, you can make them fall back every 2 weeks, at least for 1 or 2 months. So that will get their confidence and all. Is it possible if they are very distant place, you cannot do that?
Actually, they are staying in Nelambur. Actually,
So it's a distant place. So in that situation, what is the alternative you will consider? They cannot come from distant place every 2 weeks. So What is the alternative you will suggest?
You may communicate with the nearby periphery hospital, government
Yes,
hospital.
that is a very important. So you will interest the follow-up at the nearby pediatrician also. So that you can every 2 weeks let them follow up, and every 4 weeks or even 8 weeks you can also follow. So this is the one method you may have to do many times. Regarding families, I think better you can ask any family history of resistant approach syndrome. That is one point. If the steroid sensitive approach syndrome in the siblings or first degree relatives means no need to worry, because this baby also will be having, so maybe a minimal change disease only. But suppose another family member is having a resistant approach syndrome, what is the implication? You are supposed to do a genetic study in that case.
Genetic study.
So that is you can just ask about the resistant approach syndrome, one of the family first big relatives, siblings and the parents. Okay.
Coming to the
Examination.
Child is alert, playful, and cooperative. There is bilateral pitting pedal edema, which was present, which extending below the knee. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Pulse is 84 per minute, regular, normal volume and character. All peripheral pulsations felt equally and bilaterally. Respiratory rate is 26 per minute. BP is 90 by 60 millimeter mercury in right upper arm. 90th percentile is 112 by 72 millimeter mercury. Temperature is normal. Anthropometry, weight with edema was 20 kg, and without edema, dry weight is 18 kg. Height is 108 centimeter, between 0 and -2 sets go. Weight for height is at 0 sets go. BMI is 15. This is the growth chart.
So you are very important that all the children with an approach syndrome should be maintaining a growth chart according to age. If they above 5 years, you use IAP growth chart, which is more ideal. It contains weight, height, as well as a BMI chart also. Suppose child up to 5 years, which is the chart we are supposed to follow?
WHO.
WHO. For BMI?
For BMI, more than 5 years IAP.
Up to 5 years?
WHO.
How many? What are the charts?
It.
What are the charts about available for BMI in WHO?
Less
How
than
many
5 years.
charts are available?
Less than 5 years, 5 to 18 years. 5 to 18 years for IAP.
So BMI chart is above 5 years also. Is the WHO available?
Yes, sir.
Yes. Okay, so that may be needed clarification. Sometimes you may be asked because you are not sure. So any question may be asked based on your presentation. So BMI up to 18 years, WHO set score chart and the Sendai chart is available. So even this case also you can use the WHO chart, either set score BMI chart or the Sendai BMI chart. Okay, so this is there is no obesity. Okay, height is normal.
Height is normal, 108 centimeter. 50th
So
percentile is
what are
110
the
centimeter.
cutoff point for your modification or treatment? So CDC chart, somebody has asked about CDC chart. CDC chart is not useful in India, it's mainly only for the US children. And they also use up to 2 years, they use CDC chart. After 2 years, even US people also use WHO chart. Okay, so regarding this, what is the cutoff point for definition of short stature? And because you are concerned with the two important points, one is the BMI.
Less than -2 standard deviation. Height is less than -2 standard deviation. It's short stature. And BMI, if it is more than 27th adult equivalent, this obesity.
So suppose you find the obesity and the short stature or short stature. So how will you modify any change in the management? Suppose not in this case. Suppose you are treating a child with frequent relapse in Apert syndrome.
Then the dose of the steroids should be given low, not 2 mg per kg. We have to give 1 mg per kg and also for shorter duration.
Okay, so I think that this is a significant stereotoxicity. You have to take it as a significant stereotoxicity. So you have to add sparing agents. That's why you are monitoring the height and the BMI very regularly. At what interval you will be plotting the these measurements?
Every 3 months.
3 months at least. Every 3 months you should be. So any BMI exceeding at a significant pushing oil or a significant flattening of the height should you have to consider starting. You have to reduce the existing dose, whatever the dose. Whether it can be, it may be 1.4 milligram per kg per kilogram body weight, or maybe 0.2 milligram per kilogram body weight. Still, there is a flattening of height or BMI increasing because there will be individual variation. So you will be adding any of the sparing agents.
Sparing.
Okay. So regarding that chart, one question is up to 2 years WHO later CDC. Up to 2 years, we don't use CDC chart, mainly use children. So up to 2 years CDC and after 2 years WHO. Okay. Continue.
Head to foot examination. Head appears normal, no facial dysmorphism. Facial puffiness is present, no cataract, no ears, no anomalies, no preauricular tag. Oral cavity is moist, no dental caries or thrush. Throat is normal, no rachitic rosary Harrison sulcus. Abdomen is distended and also its frontal edema is present. Nails are normal. No pyoderma or rash, no features of rickets. Acanthosis nigricans present over the nape of the neck. No features of stereotoxicity like buffalo hump, moon face, truncal obesity, striae, telangitis, or hypertrichosis. Joints are normal, spine normal. There is no tenderness, no features of any dehydration.
Okay, so general examination, please 2 points you clarify. What are the signs of dehydration you look for? Signs of hypovolemia you have assessed for? Oh, you will be assessing during that on the first day of the illness of this case. Now that is resolved.
Hypovolemia, as for the history, if there is any head, abdominal pain, vomiting, is any lethargy. And on examination, look for the pulse if it is there is tachycardia or if there is steady pulse. And look for the capillary filling time. Look for the BP if there is hypotension. Look for the oral cavities is moist or not. It's a sunken eyes, skin turgor.
Okay, so this is very important because one of the commonest symptom, hypovolemia can occur without a symptom also. So whenever you see a child in relapse, hypovolemia should be assessed. Muscle cramps is one mentioned as a very important specific symptom. Dehydration, thirst, oliguria is another important specific symptom. Then regarding the findings, tachycardia, blood pressure may be either low or even hypertension can also occur. It's also important. You should be aware of that. And postural hypotension is one of the important tests you can adopt if they have a still in doubt. So postural hypotension also suggests hypovolemia. So in this case,
Hello.
Hypovolemia symptom wise as well as because you have okay. Yes.
In general examination, Rosa, better mentioned most common things missed are the cataract is very likely to be missed. And one thing you missed is the muscle. You should be making him sit and stand. Proximal muscle weakness is very important. In the general examination, as you already discussed, the short stature and the BMI is very important. And other things, sometimes the other conditions like joint is important, underlying conditions need to be looked for in the general examination. Not in this case, it's almost fairly typical case. Otherwise, a little older age group, connective tissue disorders evidence should be looked for. Micronutrient deficiency part to be looked for. Drugs and toxicities, especially in a case like this, where you are out, he was out of your care and eyes treatment and all, they may be putting on some drug which are toxic. So drug toxicity of the same drug of modern medicine, drug and toxicity from other types of medications, and nutrition deficiencies which are also possible in this case. And of course, the muscle weakness is something to be looked for.
Okay.
And also because of these steroids, many of them will have tinea versicolor. And some will have tinea corporis, extensive tinea corporis also. That also should be mentioned. And the scrotal skin may be eroded. So you have to examine the undersurface of the edematous scrotum. Perianal rash may be there. Candidiasis, trigo may be there. All these may be indicating some immunosuppression and comorbidities because of steroids.
One point, this is a typical case, as Dr. Krishnan already pointed out, while you take the family history. For few of the cases, a very younger child, 1-year-old child or 9-month-old child and all, a typical family history of the dialysis and the other high degree resistant type of nephrotic syndrome in the history. And in the general examination, certain clues in the appearance, dysmorphic facies is very important.
Yes.
Okay.
Okay, so that's about general examination. One is that always you be ready with the significant stereotoxicity should be very important point. If you get any of the, if you happen to find out any of the significant stereotoxicity, you have to start the sparing. So always it should be very thorough with the list of conditions considered as a serious significant stereotoxicity. Please, for the other participants, what are the list of conditions? Please enlist that. Can you enlist? You have mentioned few here.
Hyperglycemia.
Hyperglycemia. Okay.
And FPS more than 100 or PPVS more than 140 or HbA1c more than 5.7 or if there is evidence of cataract, glaucoma, osteoporosis, muscle weakness, short stature, that is less than 2 standard deviation, height less than or obesity, that is BMI more than 27th adult equivalent. These cases we have is considered as significant stereotypes.
So there, 2 more points is on psychosis is also one of the important side of it they have mentioned, and striae, significant skin striae is also being a cosmetic reason. It is may be irreversible also. So striae you should not allow it to progress. So these are because later on they may have a litigation also. So
one thing is make him sit and stand for proximal weakness. Make him sit on one foot, one leg, because slipped femoral epiphysis on the hip problem due to high dose of steroid long duration. So these 2 things are.
yes. So okay, we can move on to the next.
Examination of GIT. Oral cavity, there is no dental caries or thrush, throat is normal. Abdomen, inspection, abdomen is distended, umbilicus is everted, flanks are full. All cottons moves equally with respiration. No scars, dilated veins or erythema of the skin. Total edema is present, there is no inguinal hernia. On palpation, there is no tenderness or local rise of temperature. Abdominal wall edema present, abdominal girth is 58 centimeter. No hepatosplenomegaly, no renal angle tenderness, no renal mass palpable or other mass is palpable. Fluid thrill is present, and on percussion, shifting dullness is present and prop space is resonant. Auscultation is normal, bowel sounds heard, no renal fluid. Another system examination is examination of cardiovascular system. JVP is not elevated. Apex beat in the left of the intercostal space made it to mid-clavicular line. S1, S2 heard normally, no S3, no other murmurs. Examination of respiratory system, upper respiratory tract normal. Chest movements is bilateral and bilaterally symmetrical. Percussion, this resonant in all areas. It's normal vesicular breath sounds with slightly reduced intensity heard in the right internal infrascapular area. No other added sounds. Examination of nervous system. Higher mental functions are normal and cranial nerves normal and motor system power grade 5 in all limbs. No proximal muscle weakness. Reflexes are normal and there is no tenderness over the spine.
One point, how is it identify cellulitis also not very commonly seen, it's uncommon. Complete. How will you identify what are the presentations? Maybe unless you are aware, you may miss.
Cellulitis.
During relapses, spreading cellulitis is another serious complication.
There is edema, swelling which is rapidly progressive with erythema, tenderness.
Yes, mainly it may not be a redness and the swelling may not be much. Sometimes maybe only pain in diffuse area, especially at the area of the proximal limbs, abdomen wall are the usual sites you may get. It may be spreading over the subcutaneous tissue. So only pain may be there. So redness may not be present. Okay. So somebody told
you mentioned about the respiratory system examination, a little thing. Normal vesicular breath sounds, the reduced intensity in the right inter and the infrascapular area.
Yes.
But the percussion is normal. So in this case, very, very important because you are dealing with a case with the significant ascites. And what was one question in the case of fluid thrill is present, whether there is a need for shifting. It's not needed. Significant free fluid is there that itself will shift the percussion point in the lower interscapula. Should be bilateral. When it is in the unilateral, you need to check because is there any other reason? Because but the reason here is normal. Okay. So one side only is there, intensity is there. Is there any other reason to explain for that?
There is no other respiratory symptom and no added sound.
So when you present some of these findings, because there can be, you will be in trouble to explain. That's it. Okay.
okay. Yes. I think the examination part. Hello.
Hello.
Okay.
Sajna can mute the phone.
Okay. So sometimes child can have hypervolemia also, fluid overload also. That also. So you have mentioned about the JVP and hepatomegaly is also important, and sometimes basic props can also occur. So not always hypovolemia. Occasionally you can get hypervolemia. You know that two mechanism and all of edema, isn't it?
Yes.
Yes.
Overfill hypothesis and
overfill is also possible. Not very common in children, but it's still occur. So look for hypervolemia also in a child coming with edema. Okay. I think the examination is, we have discussed most of the points. Almost covered.
Yes, sir.
We have covered. Okay. So we can diagnosis. Okay.
diagnosis. Nephrotic syndrome, infrequent relapse nephrotic syndrome, fourth relapse. Probably this might be due to gastritis because no evidence of any hypovolemia and no evidence of any SVP. So abdominal pain might be due to gastritis.
Okay. Anybody, any suggestion from the participants? Any diagnosis or is it acceptable? Any please give your diagnosis in the chat box. Nephrotic syndrome, okay. Infrequent lapse also you can the frequency of symptoms. Okay. Agreed. Nephrotic syndrome, what nephrotic syndrome? Can you specify more?
It's a infrequent relapsing nephrotic syndrome. Probably if the age is 50 and no other complications. So and this most common is minimal change disease. So probably it will be minimal change disease.
Probably minimal changes. That is also you can attempt because there is no symptom signs or any history of any lab data regarding a significant lesion of nephrotic syndrome, isn't it? So probably minimal change nephrotic syndrome is possible. Okay. Infrequent lapsing because
There is no infrequent relapse by definition. Frequent relapse by definition is 2 episode within the.
okay, we have during the discussion part we have cleared that it's only a infrequent lapse. Is it an steroid dependent? Somebody has asked.
Steroid child is on last 2 relapses is developed child while child is on low dose on alternate day steroids. So by definition can be.
2 relapses,
steroid dependent.
both relapses occurred
Yes.
while taking steroid.
No, on alternate day steroids, but not on the child is not on reducing steroids recently.
Okay, so that was taking steroid while tapering steroid developed relapse, isn't it?
No.
Is it like that?
No, not on tapering. The child is on the same medication for the last 3 months. On 0.5 mg per kg per day for the last 3 months.
So there was no tapering steroid. So
No
can you
recent
take it
reduction.
as so how will you
The
answer that
child is
question?
on
Is it a
steroids now. So while
Yes,
on
yes.
steroids, if there are 2 relapses, it is steroid dependent.
yes. Child is taking already on steroid. That means child was maintaining remission while taking steroid, and that dose was not enough for maintaining that remission. What was the dose of steroid?
So this cannot be diagnosed as infrequent relapsing because child is on long-term steroids now. SDNS means it's more serious than frequently relapsing. So it is because of treatment, we think that it is infrequent relapse. Child is on chronic steroid intake. So there are 2 relapses, sir, isn't it like that?
Okay, I
Steroid.
think
SDNS.
you have to consider replace the infrequent lapser by steroid dependent approach. Because that was 2 relapses occurred while taking steroid. So that's enough for steroid dependent. Then once you make a diagnosis steroid dependent nephrotic syndrome, there is no question of frequent lapser or infrequent. That 2 terms is not there's no relevance. So you can replace it.
Provided the treatment given was appropriate. If it was given without any indication, then we can't say. But if it was given properly and child is developing relapse while on 10 mg, then it is SDNS.
In this case, a bit difficult to decide because the child was not supervised. There is a very chance that it is a steroid dependent. So plan is this episode should be very much supervised to decide this thing.
Yes, sir.
Yes. So you can modify your diagnosis as a steroid dependent nephrotic
Steroid
syndrome.
dependent nephrotic
And the threshold also you can. What is the threshold? That's also important
Point.
by making a diagnosis. It's a high threshold,
low threshold.
low threshold.
It is
Less
low
than?
threshold
Less than?
because it is
What
it is 0.5 mg per kg. So it's less than
Less
0.7.
Less than 1 mg per kg is a low threshold.
Threshold.
The relevance is that suppose it's a more than 1 mg per kg per dose, you have to use a higher order sparing agents like
Agents. Cyclophosphamide.
tacrolimus, cyclophosphamide or tacrolimus or high dose MMF, etc. Okay, so this is a 4th relapse. Okay, you can take it as a 4th relapse, you can take it as a higher. So steroid minimal change in nephrotic syndrome, probably minimal change in 4th relapse. Then steroid-dependent nephrotic syndrome, isn't it?
Yes,
You
sir.
can modify your
Diagnosis.
diagnosis, and gastritis. All the participants, is it agreeing with the gastritis? Like in a child with nephrotic syndrome, presenting with acute abdominal pain and oliguria was the, and child was not getting any medication. What is the cause for gastritis usually in nephrotic syndrome?
Steroids, due to
Steroids.
steroids.
So was the pain before steroid or after starting treatment?
Before the
Before starting steroid.
hospitalization.
Before starting high dose steroid. So better. Yes.
The child was started on high dose before the hospitalization. 2 days prior to the hospitalization, they consulted nearby and the dose was increased. Probably that might be that might contribute to the abdominal pain. If there is no other features of SPP.
Okay, I think in that case you have to clarify that also. That was started to steroid before coming, high dose steroid, and was the you have to abdominal pain. You have to characterize more clearly. Was it associated with the food intake? Was it worsening while food intake? Was it a location burning type of pain? Was it any hematochezia like melena was associated? Persistently vomiting. All these points was needed for making a gastritis. But this child had oliguria also and abdominal pain also.
Hypovolemia.
Because I don't think gastritis is a good diagnosis for this your abdominal pain, because it's only exclusion diagnosis as far as in pediatrics. The gastritis is not very common in children, and even with the high dose steroid, acute gastritis is not very commonly seen, and it's only exclusion diagnosis. So you will be in a child with massive edema. Either hypovolemia or spontaneous gastritis should be considered. So it will be very difficult for you to explain gastritis, I think. Sir, what's your, sir? Sir?
Yes, yes. I thought initially it was a hypovolemia as mesenteric ischemia itself in this case as a reason for abdominal. It happened much early before the drugs.
Yes. Hypovolemia also very commonly seen, not very rare. Most of the cases will be having. Better, this is only last diagnosis you can take gastritis, because always you should not miss, highly consider high index of suspicion of gastritis as well as spontaneous bacterial peritonitis. High index of suspicion, you should be considering first preference. And hypovolemia can be mild symptoms, no symptoms, or significant symptoms occurs only very few percentages. And better you could have correlated oliguria along with the abdominal pain. So oliguria, was it oliguria associated with along with the abdominal pain? Was there any oliguria? You can consider that.
Oliguria during the episode of that abdominal pain and oliguria was on the same days.
Okay, then there is no confusion. You can very easily correlate these two. So these are the two important, very established symptoms of hypovolemia. Okay.
Even if there is no features of any dehydration, then we can tell.
Dehydration may not be always present, may not be detected. So these are any of the symptoms you have to consider. Maybe having tachypnea alone, can have a lethargy alone, can have vomiting alone. Vomiting can also abdominal pain alone. So all the symptoms may not, is not, and sometimes asymptomatic also. So should not miss hypovolemia. That is important in the context of significant edema. Okay. Yes. Non-specific abdominal pain can occur as you, but non-specific abdominal pain during the, as I already mentioned, when the child is rapid development ascites can develop a non-specific abdominal pain, but it will be very rapid onset. But these are non-specific pain and the gastritis are only exclusion diagnosis. You should not first of all consider. You have to actively rule out all the treatable and morbid conditions. That's the key. Low dose steroid. Another question is a low dose steroid masking SPP. Okay, can it be SPP? This symptom? Abdominal pain. What is your answer to that?
There is no fever. There is features of a toxicity.
Yes, that I think
So-
this child is having mainly abdominal pain and vomiting only. So no systemic toxic symptom of a bacterial infection. There may be some subtle fever, may be low grade, decreased activity, lack of interest, not taking food, recent onset of significant anorexia. All these are the any of the symptoms are not there, and there was no loose stool. Loose stool is a very consistent symptom we find. So no systemic toxic symptoms, only having abdominal pain and vomiting. So probably spontaneous bacterial peritonitis is very unlikely. But you have to consider, you have to evaluate clinically, but you can consider only one diagnosis. So that's why first diagnosis should be hypovolemia, as sir has told. Yes. Because whenever you make a diagnosis, especially during the when you see a patient with relapse, you have to write that the child is having nephrotic syndrome relapse euvolemia or hypovolemia. That is the one important thing, a mandatory assessment we are supposed to make. Did you anything in the diagnosis too?
No, sir.
Growth, full diagnosis, you can growth, normal growth, fully immunized.
Immunized, fully immunized.
Fully immunized, normally growing, no obesity, no significant toxicity.
Yes.
Yes. Sir, when should we start to study?
I think a basic investigation of 10 more minutes, I think. Shanavas will allow 10 minutes, 9:30.
Okay. Okay. So, how will you evaluate basic investigations?
We will do a complete blood count. We will look for a hemoglobin, hematocrit, if there is any
Relevant
Yes.
investigation, because by the time you are presenting examination, the most of the time will be lost. So they will be asking only the relevant investigation in this case you will discuss.
Look for
Because
any hemo concentration.
for the management purpose.
Since we are suspecting
CBC. You will do CBC.
CBC,
Okay. Yes.
we look for the total counts if there is any infection, and also the
Okay.
hematocrit also for any hemo concentration. If the
Hematocrit is very
thrombocytopenia,
important. Okay.
Thrombocytopenia can be present.
Thrombocytopenia not very important. Not
Okay.
mainly hematocrit and the total count. Very
Total count.
important.
Then serum albumin, electrolytes. Serum, if hypoalbuminemia is present, because since this child is having severe edema.
Albumin,
Then
any point in your
it is
mind
less than
regarding
1.
albumin?
If it is serum albumin less than 1.5, we may need to give albumin transfusion.
Okay, there is a high demand for albumin infusion. That's why you are looking for albumin. Okay.
Then we have to look for RFT, any derangements if since the child also had reduced urine output, so we have to rule out pre-renal AKI.
What is the criteria for pre-renal?
Pre-renal, if it is any urine sodium levels is urine
RFT, renal function
RFT,
from the urea creatinine.
blood urea will
assessment?
be more. Blood urea will be more, and blood urea by creatinine ratio will,
Okay, that
will
is
be more.
called disproportionately high urea compared to creatinine. That is a urea creatinine ratio more than 100, they mentioned.
100.
That's a very useful because it's widely available in all the labs. So a clinician, you can very well utilize this. One of the CBC or hematocrit and the urea creatinine is very useful, very commonly available. You can make support your diagnosis. You can consider hypovolemia. Okay.
Electrolytes for any derangement, hyponatremia, hyperkalemia can be there. Then also urine.
Okay, suppose you find the hyponatremia, which is very common result you get. Very common value, you may get the serum sodium 128, 126 or 130, 120, 126, etc. So what is how will you approach that? Very common.
Yeah. Mostly it will be dilutional. Most common cause is dilutional hyponatremia. So if there is no, if the child is asymptomatic, then fluid restriction may be enough. If it is
Okay, symptomatic, you have to restrict. Asymptomatic less than 125, better you restrict. That is one cut of the IQ. And another aspect is that you may get a spurious hyponatremia, very common, because you will be having a hypercholesterolemia. So that will make a spurious hyponatremia. Actually, there is no hyponatremia. The osmolality will be normal in this patient. The cholesterol will interfere with the estimation of the osmolality, estimation of the sodium. So that may be ignored. So very high serum cholesterol with a moderate hyponatremia need not do anything. Okay.
Rosa, hyponatremia, yeah, maybe you will be contradicting. When there is a intravascular volume shrinking, that is what you are always considering when you're in a nephrotic syndrome. If it's an acute nephritis, dilution hyponatremia, salt and water retention is there. In nephrotic syndrome, it's the other way. So that may not be a good argument.
Okay.
then urine, urine, we will look for urine albumin. Then if it is more than 3+ or 4+ for 3 consecutive days, then it's taken as relapse. And urine PC ratio, nephrotic range that is more than 2.
Okay. So in this case, suppose you get a PC ratio 0.1 or 0.2. So what is anything? Do you consider relapse or not?
Urine
Is it
PC
all, in
ratio.
this case, is it needed? PC ratio? Not needed because the child is
The
having
child is
edema.
having edema,
So
severe edema.
it's not much important. But for the prognosis, that is for the follow-up, you may need. Otherwise, no need. Urine albuminuria 3+ is enough. Even in the absence of proteinuria, you are not making any, there's no difference in the management. Okay. Suppose you, so with this result, do you consider main thing is confusion regarding the hypovolemia. Is there an hypovolemia with this result?
Hypovolemia here, the RFT is normal.
Hematocrit?
Hematocrit is 41, it elevated. Hemoglobin is 14.7.
Okay. So
We have
what is
to
your comment on that?
Have to look the baseline hematocrit, and if it is
Baseline, is it available?
was not available.
Okay. So what is the usual hematocrit you find in your wards? Common hematocrit value you come across in the ward during your posting and all?
37, 38.
Okay, so that is the usual 37 is the usual hematocrit we find in our population. Isn't it? It's not very high.
Yes.
Why? What is the reason?
Because nutritional anemia.
Iron deficiency. Nutrition anemia very common in our population. So suppose it's a 37. So what is your comment on hematocrit?
The C concentration is there. So it is more than 10%.
10, okay. 20% is the ideal one. 20% from the baseline. Okay. So any other method to confirm rule out hypovolemia? What are other methods?
urine examination, fractional excretion of sodium, urine potassium index,
excretion index.
potassium excretion index.
So these are the urine. These tests may be useful. You can do that. You can read all of you can read about it. Any other bedside test you will do? Bedside investigation, widely available in the ICU center. You can also train in that.
Anemia.
That's a simple on-the-spot decision you can make. If you suspect hypovolemia, suppose that is in the emergency room. Hypovolemia, what is the simple? And if you have to get some train.
IVC, ultrasound, IVC
IVC, that's
collapsibility
a very
index.
useful. Yeah, you can utilize that, isn't it? So what is that cutoff IVC collapsibility index? What is that cutoff for hypovolemia? Because most of the centers are currently available in the ICUs and emergency room, so you can utilize. So IVC collapsibility index more than 50%. Okay, if it is more than 50%, that also very strongly support the hypovolemia. You can use IV fluid or you can give albumin safely. Otherwise, you will be reluctant to give fluids and albumin. That is important because ruling out hypovolemia is very important to diagnose also because for using diuretics as well as giving fluid or albumin, both very important. So you should be well versed with how to clinically suspect it, diagnose by simple lab value, and also radiology. Urine also you are supposed to use these indices. Okay. Okay. Then anything else, sir? Anything? Fiji? Anything else? Investigation?
I think management needs another session, full session. We'll stop here, I think.
Okay.
9:30 already, le.
Okay. So one important hypovolemia, since we have been discussing most often in the hypovolemia, how to manage hypovolemia simply.
Hypovolemia, we give 20 ml per kg of normal saline over 30 minutes.
Normal saline. 20
Two
ml is
bottles
important.
can-
Then
bottles
you can
can-
repeat once again.
There is no improvement.
Response.
Albumin, 20%
So
albumin.
so you may be
There is-
asked whether you have been using this, and you should be well versed in answering this, because you will be managing a lot of children with hypovolemia and also nephrotic syndrome. So what precaution will you do by giving?
If there is any hypertension or if there is any respiratory distress that can burst, pulmonary edema can occur. So we should give
You should be
slowly over
more
3 to 4
careful.
hours. Monitoring is
Very
required,
slowly.
and
Monitor.
over 3 to 4 hours, 0.5 to 1 gram per kg, 20% albumin.
Okay, 20%. Suppose what is the cost of albumin infusion?
10,000.
Around very costly. You
10,000.
cannot take a risk. So most of the time you have to adopt IV fluids. Any other? Suppose you want to give albumin. So any other alternative available?
FFP,
Plasma is also important. What is the dose? You can use that. What is the dose? How much you will be?
15 ml per kg.
Okay. 20 ml per kg. You can repeat also next day. So that's another alternative. Okay, sir. Anything to add?
Yeah, nothing.
So any doubt from the participants? I think they have yeah, long session. Is there anything add?
No, sir.
ബോക്സിലൊന്നുമില്ല അല്ലേ?
And that we all answered.
Answered. So with that we have been almost management part we couldn't do because we have been most of the time in the examination by the time investigation managed very quickly will be finishing. So was presented very well in this case. She has discussion was possible because she has gone into all aspects of the case, starting from the history of present illness, essential points were added, and the past history also elaborated, and the immunization history, all the components of history. Mainly, the history is the most important. That also important. We mainly discussed on the history, so that's also highlight. We would like to highlight that point also. In any case, history is the most important part by which you diagnose. For the management, also we could discuss essential points. Like hypovolume infection, we couldn't discuss much, and the specific treatment also we couldn't discuss much. So with that, Sir Purushottam sir, Fiji, you can add after that,
Nothing
Purushottam
more.
sir.
Nothing much, sir. For the postgraduates, I will recommend the Krishnan sir's writing on nephrotic syndrome, and there is a parents' guide book also, sir, written in Malayalam. So going through these writings are very useful for postgraduates to answer questions in the exam. All of the postgraduates can access that. PGs in IMCH may be having that PDF.
Okay, Purushottam sir.
ജോസോ ഷാനവാസോ ഇല്ലേ? വിഷ്ണു വൈൻഡപ്പ് ചെയ്യാൻ. ഇല്ലേ? ഷാനവാസ് ഇല്ലേ ഇന്ന്?
Sajina is there. Sajina, can you any comment on that, Sajina?
Sir, it was a very excellent class. Most of the topics have been covered very, very beautifully. I think I think almost all the topics are, except maybe some management of steroid-resistant nephrotic syndrome. I think almost everything has been covered. Thank you, sir. Thank you so much.
Sajina is assistant professor from Ernakulam Medical College. She is looking after the nephrotic syndrome cases, nephrology cases at Ernakulam Medical College. Okay.
ഓഫീസ് ബെയറേഴ്സ് ആരും ഇല്ല? ഉണ്ടോ?
Anything to mention? Rosen എന്താ പറയണ്ട ലാസ്റ്റ്?
ഇല്ല. ജോസ് ഇല്ല, ഷാനവാസ് സാർ ഇല്ല, വിഷ്ണു ഇല്ല, ഉണ്ടോ?
ഇപ്പൊ റീസെന്റ് അവര് എക്സിറ്റ് ആയത്.
ഇല്ലേ എന്നല്ലേ? അപ്പൊ കുഴപ്പമില്ല. അപ്പൊ നമുക്ക് വൈൻഡപ്പ് ചെയ്യാം. അപ്പൊ കുഴപ്പമില്ല.
ഓക്കെ.
ഗുഡ് നൈറ്റ് സർ.
ഗുഡ് നൈറ്റ്. താങ്ക് യു. എല്ലാരും റോസ് നന്നായിട്ട് പ്രസന്റ് ചെയ്തിരുന്നു റോസ് കേട്ടോ.
Thank you.
ശരി എന്നാ. ഗുഡ് നൈറ്റ് എല്ലാവർക്കും. ബൈ.
ഓക്കെ.